Hello, good afternoon, everyone. I'm Dr. Lam from Queen Mary Hospital. I'm an associate consultant in the Division of Immunology and Immunogenetics. First of all, I would like to thank Hong Kong U Space and Dr. Tim for the kind invitation for this talk. So I'm a fellow in immunology in Hong Kong, UK, and Australia, and I have got special interest in allergy, immunodeficiency, as well as autoimmunity. So today I'm going to talk to you to walk you through a topic of immunology within reachable distance. We are going to talk about 3 patients with immunology and allergy conditions, about the underlying pathogenesis, as well as the laboratory diagnosis that can be helpful in the diagnosis of these patients. First of all, we got a 3-year-old boy. He got poor growth, extensive eczema with history of methicillin receptor resistant Staphylococcus aureus colonization. So that is a very common bacterial infection in case of like very poor eczema. And he also got some recurrent VC attack. His first attempt of penis was actually quite late, at 3 years of age. At that time, he did develop urticaria rash, angioedema, and vomiting within few minutes after intake of a penis soap. Other allergies include also eggs and milk with similar presentation as above. And we performed the skin prick test for the patient. So for the skin prick test, the penis was positive. So for skin prick test, we got like a positive control and negative control as laboratory test as well. The positive test is the histamine test. And actually, when we talk about allergy, we will talk about sensitization phase and effector phase. So this is like a diagram that is annotating this process. For the sensitization phase, is the first encounter of the allergen with the body, and then they will be taken up by like antigen presenting cell like dendritic cell, and the dendritic cell will present them to naive T cell, which will switch to Th2 cell. For Th2 cell, they will secrete some cytokine, for example, the interleukin 4 and interleukin 13, and then they will stimulate the naive B cell into IgE cast switching. And the IgE cast switching will produce some of the allergen-specific IgE, and they will bind onto the IgE receptor on the basophil and the mast cell. So this is a sensitization phase. When upon the subsequent exposure of the allergen that will become the effector phase, the allergen will bind onto the IgE on the IgE receptor of the mast cell and the basophil, and those cells will degranulate, releasing a lot of like histamine, tryptase, etc. And those will have got like the allergic response that we have. And they can also recruit further like molecule in which they will recruit like eosinophil, etc. They will give some of the late phase response. So when we talk about allergic response, actually we are talking laboratory diagnostic. We are talking about basophil and mast cell. Actually, we can test them by using different methods. One of the most famous methods is for sure the skin test. Many of you have heard about that before. So actually, that is make use of the cutaneous mast cell. We introduce some of the allergen using the needle prick onto the mast cell, onto the skin, and then the allergen will cause the IgE on the Fe receptor of the mast cell, producing the histamine, etc. And then there will be a real response on the skin of the patient. And also in the laboratory, actually we can have the direct detection of the specific IgE. For example, in this patient, the specific IgE to peanut. And also, we are going to talk more about the specific IgE. For specific IgE, we can either take the food as a whole component, the whole allergen, or we can break down the IgE into small components, for example, which is known as the component resolved diagnostic. So for peanuts, we got like the component like the RH1, 2, 3, 8, 9, etc. So for those storage protein that is RH1, 2, and 3, that is very stable, and there is a very high risk of like severe allergy. And there is also other component, for example, like RH9, that is a quite stable protein as well, and that can give to a very severe reaction. However, for other components, for example, the PL10, because they are very labile, and so actually the reaction can be very mild. For example, just some mild itchiness. So that doesn't really prevent the patient for further intake of relevant food substance in case that is just a single positivity. In our patient, the total IgE is a bit high. So total IgE is very important in the interpretation of our patient, because in case of total IgE being high, so all the specific IgE can be very positive. So there can be some non-specificity. So, but like in our patient, actually, despite the peanut specific IgE is high, there is a very high standard of RH2. So that is a very specific to a genuine and persistent peanut allergy. So this patient is actually very likely to have persistent peanut allergy and should be avoiding peanuts. So for the component resolved diagnostic, actually you can see a lot of like small number over here. So it seems to be very compact, but to us, actually that is very good, because that can be help us to stratify whether the patient got a high risk or low risk of allergy, and whether we can introduce the relevant food substance for the patients. And these are some of the summary slides, like the result, how can you put into different approach of like whether food allergy, respiratory, or like latex allergy, etc. So, and the other test that we can use nowadays is quite a like more new test that is known as the basophil activation test. So when I told my patient, actually I will say that usually before we usually do the skin test, do the skin test or feed like the patient with a food substance. But now we are actually feeding the patient's immune cell with a relevant food substance. So we are given we take the blood of the patient, and we add the specific allergen to the blood sample. So in case of the presence of the specific IgE on the IgE receptor of the basophil, they will cause then the IgE on the IgE of the IgE receptor of the basophil, resulting in the upregulation of a molecule which is known as the CD63, and we can measure it using a flow cytometry. So we're going to talk more about flow cytometry, but basically that is a machine to measure the cell surface molecules. And in this patient, the best CD63 to peanuts is positive, which is another supportive evidence of the patient is going to have like a genuine reaction when he take peanuts. So as to summarize, the skin test and blood test are both positive to peanuts in this patient, and we diagnose the patient as peanuts allergy, and we told the patient to carry the adrenaline pen, and that is the medication for rapid relief of symptoms. And actually the patient we will consider to put this patient on oral immunotherapy, which we give the patients like a controlled dose of like peanut substance in a medically supervised way. So we to teach the immune system how this is not really a harmful substance again, but this need to be under like careful medical supervision. And without a correct laboratory diagnostic, it's not possible to have this management plan. So this is the first case that we are discussing today. And so do you got like any question for this case? So in case no burning question, maybe we just move on to our second case. Our second case is a 48-year-old lady. She got unremarkable past health. However, one day she presented with acute confusion with high fever up to 40 degrees Celsius, and also her neck is very stiff. So at that juncture, we also examined her. She doesn't have any respiratory, abdominal, or urinary symptoms. So that can account for her high fever. So initial diagnosis was thinking about whether she got a central nervous system infection, which include like probably a brain infection, etc. Initial investigation included a peripheral blood count, shows that the red blood cell count was normal, hemoglobin and platelet was normal, and the clotting profile, like acute phase reactant, CRP, and liver renal function tests were all okay. and the brain image and the CT brain was performed. There isn't any brain edema, space occupying lesion, and the brain doesn't have any hemorrhage or coagulations. At that juncture, she can and the cerebrospinal fluid was taken by the lumbar puncture, which is we do it over the back of the patient to obtain the fluid from the central nervous system. So we want to see what is the process that is going on there. So you find to be have a very high white blood cell count over there with lymphocyte predominance. Because it's busting in nature, so the total protein cannot be performed. However, the CSF protein level is really low. So that is like a possible few cause. One of the possible cause of this phenomenon is like infection. So tuberculosis infection. The other thing is maybe that is due to inflammatory causes. Process. A extensive microbiological workup as stated here was performed, but that is all negative. So that include bacteria, fungus, virus, as well as initial TB screening is all negative. However, TB culture will take much longer time, so that is remain to be one of our differentials. The patient was started on an empirical course of intravenous cephalosporin and acyclovir, that is an antimicrobial as well as antiviral. However, she deteriorated really quickly. She required ICU admission, intensive care support due to coma, and she could not breathe. She got respiratory failure. She needed to be intubated. And lumbar puncture was performed 6 days later. The white blood cell was actually climbing even higher, and still lymphocyte predominance, and the CSF total protein is really high with a low CSF to blood glucose ratios. So at that time, since what we mentioned, TB cannot be ruled out by the initial investigation, we need to have a very long time for the TB culture. So the patient was started on empirical anti-tuberculosis treatment together with steroid. That is a standard management of TB meningitis. So after the TB treatment as well as the steroid, actually the patient have some slight improvement. She has become more conscious. She can obey commands. However, she was still dependent on ventilator, and actually she need to be tracheostomized after 2 weeks. So we need to place a hold on her trachea to help her breathe. So actually her clinical stage was really, really bad still. And at that juncture, she cannot eat well. She got severe dysphagia, and she need to have the nasal gastric tube feeding. So there is a feeling that actually the patient isn't the diagnosis of the patient isn't really TB at that juncture, and further physical examination shows some cerebellar signs like multidirectional nystagmus, and also she cannot move all her limbs, spastic tetraplegia, and she also got some of the reflex that is really weird. And her sensory, and for her hearing, she got severe bilateral sensory neural hearing loss. So for that juncture, what we are going to do, and what we mentioned, one of the cause is suspected infection. The other cause is suspected inflammatory causes. In the brain inflammatory causes, one of the cause in this age group is about autoimmune encephalitis. And for autoimmune encephalitis, actually that is diagnosed in our laboratory using an indirect immunofluorescence slide. So this is a tissue slide. For example, that can be, for tissue slide, we got a lot of different type of tissue slide. But in this patient, we use the monkey cerebellum as well as the intestinal slides. And this is and we will add the antibody in the patient. We'll add the patient's serum sample in case there is an autoantibody presence that will bind onto the ligand, And then we will add the secondary fluorescent label antibody to detect the presence of autoantibody. So we need to have A plus B plus C before we can see the fluorescence here. So we use the fluorescent microscope, and this is a very talented scientist, and he is like reading the microscope, reading the slides under the microscope, and we will see like fluorescent images. How about this patient? So this is an image for this patient's serum after we use the fluorescent microscope. So this is the monkey cerebellum, and this is the white matter, and this is the molecular matter, and molecular layer. So probably in case you retain some of your high school like biology, and we will see like there is many stars over here in case you can see. So those stars are actually the astrocytes. So that is the fluorescent pattern of the astrocyte of the cerebellum. And also, there is also some immunoglobulin that is bind into the pear, the Berman ganglia. And for this, actually, that is like also a positive staining. And we say this antibody is like, this pattern is typical of anti-GFAP pattern. So anti-GFAP is an autoimmune encephalitis, and in these patients, she was started on immunosuppressive management. For example, in intravenous immunoglobulin, post-steroid, plasma exchange, as well as rituximab. Rituximab is an agent to delete the B cell of the patient. So as the B cell got some reproduce the pathogenic antibody. So besides removing the antibody, we also try to remove the source of the antibody. So, and after the management of the patient got improvement in hearing, and she got successful weaning of tracheostomy and angiotrip feeding. So she can breathe on her own, and she can eat on her own again, and her upper limb power regained. Although the tetraplegia that is improving slowly, but actually over like 1 or 2 years later, she can walk independently with a stick, and the brain encephalitis and myelitis was actually much improved. And actually, she's like living a normal life now after like a few years. So, and the CT abdomen, because of this antibody, we need to search for any tumor, but the tumor fortunately, the tumor screening in this patient was negative. So in case you are curious, you want to know more about this case, you can refer to our publication. And actually, this is the first GFAP patient we have diagnosed in Hong Kong. So it's like 7 or 8 years ago. And at that time, actually, Mayo Clinic just diagnosed a couple of cases. But we can see that actually a diagnosis of autoantibody can change the life of a patient. Although some of the disease cause can be very complex, but however, in case we know the underlying cause, using some of our immunofluorescence assay, we can change the management plan and better help the patient. For the indirect immunofluorescence, actually, we can use other tissues like one of the example is that we can use like the monkey, the animal kidney as well as the stomach tissues. So this is an example of an anti-mitochondrial antibody. So when we talk about mitochondria, again about high school biology, maybe you will remember like mitochondria is like the power bank of the body, so powerhouse of the body. So it is present in many cells, like in kidney, like in stomach. So that is the case. So all of these cells will nice up in the anti-mitochondrial antibody presence. So, and for us, clinically, when patient present with some of the liver function derangement, for example, the patient may present with jaundice, may present with tea-color urine, pale stool, etc. And of course, like in Hong Kong, we will think about like a hepatitis B infection, alcoholic cirrhosis, etc. But in case like all the causes are ruled out, like one of the other causes that we need to think about is like primary biliary cholangitis, etc. So that is like what is working, what is used for the diagnosis. So we can use a blood sample possibly for the diagnosis of this antibody, and for sure like other like biopsy or like we will also aid in the diagnosis of this group of patients. So, and in case like this case, in case it's like okay to all, I'm going to move on to our third case, and we're going to allow some discussion at the end for all of you. So our third case is a 5-year-old boy, and he fell ill nearly every month, and most of this episode are upper respiratory tract infections. So I'm not sure, like, for some of you here, maybe some of you got like sibling, or some of you maybe got some young kids who go to kindergartens. So maybe you would say that, oh, it's really common for those kids to have like URTI, like upper respiratory tract infection, when they go to kindergarten. Like it happens like every month, every time like a kid will become sick, and then the other kid will get infected, and that is actually quite normal. But what happens in this boy is actually about the last year, he got 3 episodes of pneumonia, that is a lung infection, and 1 episode of otitis media, that is a middle ear infection. And he required a week of hospitalization for pneumonia and otitis media. So that is not really a simple URTI he experienced. He actually experienced some of like the more like harmful infection, or more strange infections. And besides, he is always the shortest one in his class. So, and then to an immunologist like us, we will think about like the 10 warning signs of primary immunodeficiency. So we can refer this diagram. So they include a lot of like middle ear infection, lung infection, etc. And like the patient is being really short in stature, and yes, they got like a few things here. And in our patient, we got like the patient is being hospitalized for his infection, and he is really short in his stature, and etc. So this made us really wondering whether this patient is actually normal or is he abnormal. And then because one of the features is the family history, so we asked more about the family history. We found that actually one of the maternal uncle also suffered from recurring infections since childhood, and he passed away before he reached adulthood. So the family history is very positive. And further investigation, which we found that the immunoglobulin level IgG-AM is very low, and there is no B cell by flow cytometry. So what is mean by IgG-AM? So for IgG-AM, maybe recently, I mean in recent few years, after COVID, you have heard about like COVID vaccine and everything, and we talk about like the antibody. So the IgG-AM is the antibody that is help us to fight against infection. And after vaccination, actually, this antibody can build up and help us to fight against relevant infection. And what is B cell? And B cell is something that is producing the immunoglobulin. So when we talk, first of all, I'm going to talk about how we detect like the IgG-AM and also the B cell in our laboratory. So this one is the way to detect like the IgG-AM. So for IgG-AM, we detect them using like the immunoprecipitation reactions. So when we add like the antigen and antibody together, they will be forming like the matrix. Uh, they will forming the matrix, and so and in case we are adding more and more antigen to like a certain antibody, and we will have more like binding that is being detected, and eventually to the equivalent zone. However, afterwards, if more antigen is added, there will be like dropping of like the antigen antibody complex. So we will say that the zone of equivalence is where we tend to look for. And in case of potion, there will be like a breakage of this relationship, and we cannot really quantify like the amount of the antibody that we have. So for our laboratory, or like for most of the laboratory, actually our IgG-AM is performed by using the nephelometry and turbidimetry. So we add like antigen antibody complex in a like a tube, and then we use the light to shine it through. And for the light that is passed through, we measure it using like the turbidimetry. That means the light reduction when compared to the light source. And that is like inversely proportional to the concentration of the analyte that we are testing. And we also got the nephelometry method, in which that is the diffraction of the light source at a 90 or like 10 to 90 degrees Celsius. So we measure at this angle. So in case of like a high concentration, there will be more diffraction of like a light the light beam. So that is proportional to like the concentration of the analyte. So that is the method that we detect. We have got the detection of the immunoglobulin level. While for the lymphocyte subset, just now we mentioned about like in basophil activation test in the first case, maybe about the food allergy. Probably you remember we talked about the flow cytometry. While for lymphocyte subset, actually we use the flow cytometry as well. For lymphocyte subset, we use the mixture of the cell that is labeled with a fluorescent antibody, and then they are shoot into the analyte using a single file of the cell. So the cell is passed through them in a quick speed, like one by one. So the laser beam can pass through them. So when the laser beam passes through them, they will detect several parameters. For example, the forward scatter and the side scatter, which is to detect the size as well as the granularity of the cell. So we can know what the cell that we are interested in, how they are like. Besides, we will also detect like the surface marker. For example, like the CD45, etc. And we for this one, for example, in lymphocyte subset, we detect the CD19 that is a B cell, and like a CD3 that is T cell. So this is a normal distribution, and this one is probably the NK cell in case we get on the lymphocyte. While for the patient with SLA, like in our patient, he got like no B cell but like a positive positive T cell that is normal. So we use this method to detect the absence of B cell in these patients. When talk about B cell, when talk about B cell, we will talk about the B cell maturation. B cell is actually similar to human being, in which they differ from a baby B cell that is the stem cell in the bone marrow. And then in the bone marrow, they go to school, they develop from pro-B cell to like pre-B cell and immature B cell stage. So in this stage, they got like a few things that is happening. For example, they got like the VDJ recombination. I know it's a very technical term, but basically that is to have like a rearrangement of like the B cell receptor to make sure that they can face a huge spectrum of different microorganisms to face them. And BTK is important in this process because it's important for the B cell signaling. And then afterwards, when they enter to, at that time, since they haven't encountered any actual antigen, so they are still immature B cell. And then afterwards, as they encounter like a proper antigen in the peripheral or in the lymph node, they will become a mature B cell. So, and it's like human beings. So after they go out from the university, they will be very diversified. They got different occupation. And B cell is similar. They work in different roles, fighting against different pathogens. So for our immune system, we will say that the humoral, the B cell immune response belong to the humoral component, which is part of the adaptive immunity in which we got the memory. So vaccination is the reason why it's so important, because that can be that the body can have like the B cell memory. In case there is no B cell or B cell is being very defective, so in our patient, so they cannot fight produce any immunoglobulin and fight against many bugs. So they will become sick very often, like in our patient. So this patient was put in IVIG, immunoglobulin replacement, monthly immunoglobulin replacement. So at that time, because it's a couple of years ago, the patient need to be admitted into the hospital to replace the component that they are lack of. But nowadays, actually, they can do it at home, and so they got a needle and appliances at home. They don't need to have the jab every time anymore. So and he doesn't need any more hospitalization for recurring infection. Actually, he did very well academically, and he entered medical school and become one of our colleagues. So I think this is a very encouraging story. So probably a genetic diagnosis or diagnosis for the patient is life changing. Second patient or this patient actually they can save their life or they can change their lifestyle development. So I think this is the end. I would like to thank my team on a clinical team as well as a laboratory team for their kind support in this test development as well as management of our patients. So finally, I would like to see in case you got any question, you can raise any question here.
So, Dr. Gam, thank you very much for the very informative talk. So I noticed that two cases, I think it's two cases here, are related to the genetic disease, genetic problem. Then how's the molecular test or the sequencing or basically the molecular diagnosis are applied or are used in this immunology or immunotechnology?
Thank you so much, Dr. Tim, for the question. I think the molecular test is mainly for the third patient in which he got a gamma globulinemia. So for this patient, initially our step of approach because the molecular test is very important for the diagnosis, but for acute phase of management, we will still need to give him antibiotic and we need to. But once we know his immunoglobulin level is really low, we will give him the supplements first before we are awaiting the genetic test. However, the genetic test is very important for management. For example, because he is a young boy, so maybe his mother really want to have other kids. So it's really important to know whether they got inherit the same gene. In case it's a de novo mutation, just the kid got a mutation, the mother wasn't a carrier, then that is less worrisome to the family. And the other thing is in case this is an older patient, so maybe family planning, etc., is a concern in this group of patients. So that is really important for them as well. And also it's important for that in case they got some female sibling and the mother is carrier, we also need to know they should be also very keen to know whether they are carrier and they may this generation may also inherit the same defect.
Thank you very much. Any other questions? No question. Yeah, seems no other question. Right. Okay. Right. That's okay. Yeah.
So is there any other question from online participant? So in case there isn't, maybe we will end our session over here. So thank you so very much everyone for attending.